Welcome to the deep dive. Today, we're really getting stuck into a topic you definitely need a handle on, especially if you're looking at revision notes like these ones on Acute Otitis Media or AOM.
Yeah, AOM. Super common.
Exactly. So think of this as your kind of high-yield summary. We're aiming to pull out the absolute must-knows and make them memorable, whether it's for something specific like the MSRA or just, getting a really solid grasp of it.
That's the plan. We're looking at your notes, section by section, what it is, the causes, risk factors, pathophysiology, how it actually happens, symptoms, differentials, management, all that good stuff.
Mm-hmm.
The goal is to distill it, make it clear, make it stick.
Perfect. Let's dive right in then, starting right at the top. What exactly is acute otitis media, based on these notes?
Okay, so the core definition is inflammation of the middle ear. Pretty straightforward. But the key is why. It's down to a bacterial or sometimes a viral infection.
Yep.
And the two hallmarks for diagnosis are, one, a really rapid start to the symptoms, especially ear pain, otalgia, and two, seeing fluid in the middle ear, that effusion.
Got it. Rapid onset pain, middle ear fluid. And the notes seem to hammer home that it's mostly young kids.
Oh, definitely. Peak age is often cited as 6 to 12 months old. That's when they're really susceptible.
Okay. And the notes also helpfully distinguish it from other ear things to sort of fence off what AOM isn't.
Yeah, that's useful for revision. So acute suppurative OM, that's AOM, but with pus, usually meaning the eardrum's perforated, different from straightforward AOM.
Okay.
Then there's OME otitis media with effusion. That's the glue ear situation. Fluid behind an intact drum, but it's chronic, not that acute infection and pain you see in AOM.
Right, no acute infection there.
Exactly. And then you've got CSOM, chronic suppurative otitis media, that involves a long-term perforated eardrum, and mastoiditis, which is infection spreading to the bone behind the ear, and cholesteatoma, which is like a skin cyst in the middle ear. All different beasts.
Good clarification. And the notes also mention persistent and recurrent AOM.
Yes, important definitions. Persistent AOM just means things aren't getting better, or maybe even getting worse, after an initial episode. Recurrent AOM has those specific numbers 3 or more episodes in 6 months, or 4+ in a year, with one fairly recently, like in the last 6 months.
Those numbers sound like classic exam fodder.
They often are, yeah.
Yeah.
Worth remembering.
Okay, definition sorted. Now, the SAP causes the etiology. What actually kicks this off?
Right, the culprits. So your notes point to both bacteria and viruses. Bacteria are the main players, though. Top of the list is Streptococcus pneumonia. Used to be even more common, but the pneumococcal vaccine has definitely made a dent. It's still responsible for maybe 40% of cases, according to these notes.
That's interesting about the vaccine impact.
It is. Then you've got Haemophilus influenza, or H-flu, not the type B that the vaccine covers. Usually that's around 30%. And Moraxella catarrhalis, maybe 15%. Strep pyogenes gets mentioned too, but less common.
So predominantly bacterial, but viruses are involved too.
They really are. Often, a virus starts the whole thing off. Think common cold viruses, rhinovirus, RSV, adenovirus, influenza, parainfluenza. They cause that initial upper respiratory tract infection.
Right, the sniffles and cough.
Exactly. And that seems to upset the balance in the nose and throat, making it easier for the bacteria that live there normally to cause trouble in the ear.
Okay, so the virus kind of opens the door for the bacteria.
That's a good way to put it. Which naturally leads to thinking about risk factors. Who's more likely to walk through that door, so to speak?
Yeah, good question. So who is most likely to get AOM?
Well, the notes break it down for kids and adults. For children, the biggest risk factor is just being young, especially under 2.
Makes sense.
Exposure to other kids with colds, like in nursery, is a big one. And exposure to cigarette smoke, passive smoking, also anything affecting the eustachian tube function.
And we'll get to why that tube is so important shortly, I guess.
Definitely. Other risks for kids include recent colds or URTIs, having allergies, chronic sinus problems, certain facial structure differences like cleft palate, and being immunocompromised.
Okay.
Lifestyle things too, like bottle feeding while lying flat and having family members who had lots of ear infections.
Right. And what about adults? The notes say it's less common, but what puts them at risk?
Similar themes, but just happening less often. Again, eustachian tube problems are key. URTIs, allergies, chronic sinusitis, those craniofacial issues like cleft palate or Down syndrome, immunosuppression is a factor. And smoking, active or passive, is a significant risk for adults too.
Smoking keeps coming up.
It does. It seems to impact that whole respiratory system lining, including the eustachian tube.
Okay. Causes and risks covered. Now, the pathophysiology, this is where it gets really interesting, right? How does that infection actually, set up shop in the middle ear?
Yeah, understanding the how really helps. So typically, like we said, it follows a viral URTI. That virus messes things up in the nasopharynx, the area behind the nose.
Mm.
Bacteria that normally live there quite happily can then seize the opportunity. They travel up the eustachian tube into the middle ear space. That's step one, colonization.
Okay, they get in. Then what?
Then they trigger inflammation. The body reacts. The lining of the middle ear swells up. That's the edema and starts producing fluid, sometimes pus. That's the exudate.
Right.
Now, here's the crucial bit. That swelling, the edema, blocks the eustachian tube from the middle ear end.
Ah, so it gets blocked off.
Exactly. And the eustachian tube's job is to drain the middle ear and equalize pressure. If it's blocked, fluid and pressure build up behind the eardrum.
Which causes the pain.
Precisely. That pressure pushes on the eardrum, makes it bulge outwards, and that really hurts. If the pressure gets too high, pop. The eardrum can perforate.
Ouch. But the notes said it often resolves on its own.
Yeah. Thankfully, in many cases, the body's immune system does manage to clear the infection, the inflammation subsides, the tube opens up, and it all drains away. Spontaneous resolution is common.
And there was that point about kids' anatomy making this whole pathway easier for the bugs.
Yes. This is a brilliant bit for revision. In young kids, their eustachian tube isn't just shorter and wider than in adults. It's also angled more horizontally, less of a slope.
Okay.
So the notes explain that this flatter angle makes it physically easier for pathogens from the back of the nose to get into the middle ear, especially when they cough or sneeze. It's like having a less steep drainage pipe stuff can back up more easily.
That horizontal tube is a great visual. Really explains the age link. Okay, so someone comes in with earache. How do you know it's AOM and not something else? What are the main differential diagnoses?
Good question. The notes list a few key things to think about generally. Otitis media with effusion OME, the glue ear fluid but no acute infection signs, otitis externa swimmer's ear infection of the outer ear canal, not the middle ear.
Right outside the eardrum.
Yeah. Mastoiditis is on the list, but remember that can also be a complication of AOM, and TMJ problem, jaw joint issues, can definitely refer pain to the ear.
Okay, those make sense. And for adults, the list is wider, potentially more serious things.
It is, and this is important. In adults, you have to consider things like giant cell arteritis, inflammation of blood vessels, referred pain from the heart, angina, even an MI. Dental issues are common causes of ear pain, nerve pain like trigeminal neuralgia.
Wow, quite a range.
Yeah, also migraine, shingles affecting the ear nerves, trauma, even salivary gland problems, or rarely head and neck cancers presenting as ear pain. So for adults, the net is cast much wider. Ear pain doesn't always mean an ear problem.
That's a critical point. Let's step back again, epidemiology. Who gets it, when, how often? What's the bigger picture from the notes?
Okay, so focusing on the UK context mentioned, it's super common in childhood. Peak is that 6 to 18-month window, most common overall between birth and age 4, and definitely more frequent in winter, aligns with cold and flu season.
And the link with URTIs and smoking exposure is mentioned again here.
Yes, reinforces those risk factors. Globally, the numbers are huge. The notes quote around 709 million cases a year. That's like, what, over 10% incidence? Massive number.
Yeah, and a key stat, almost 5% of those might go on to develop chronic suppurative OM. Plus, there's that worrying point about complications being a cause of death in under ones in developing countries.
Yeah.
Really highlights the severity potential.
Absolutely. And for adults.
Much, much less common. Their eustachian tubes work better, generally.
But smoking is highlighted again as a risk factor specifically for adults here. So, key takeaways from this section. Kids get it a lot, especially babies and toddlers. Adults rarely do. It often gets better by itself within a week or so.
Usually self-limiting. Okay. So let's talk presentation. What does someone with AOM actually look and feel like? Symptoms and signs?
Right. We'd see symptoms first. Sudden onset ear pain otalgia is the classic one. Fever happens in about half the cases, often preceded by those cold symptoms we talked about. In babies who can't tell you their ear hurts, look for irritability, maybe difficulty feeding. Older kids might pull or tug at their ear. Feeling generally unwell, malaise is common. And you'd expect some degree of conductive hearing loss because of the fluid blocking sound transmission.
Okay, those are the symptoms. What about the signs a clinician looks for, especially with an otoscope?
Okay, signs. Observation first. Yeah, you might actually see the child tugging their ear. But the otoscope is crucial. You're looking at the eardrum, the tympanic membrane. In AOM, it often looks red, maybe yellow, or just cloudy instead of pearly gray.
Then bulging?
Yes, bulging is a key sign of that pressure buildup. Or you might see it's actually perforated, maybe with some discharge coming out. You can also check its mobility. It won't move well if there's fluid or pressure behind it. Sometimes you can even see an air fluid level. Tenderness over the mastoid bone behind the ear can also be a sign.
Is the presentation different in teenagers or adults?
The notes make a point here, yes. Otalgia, the pain, is still common. But, and this is important, they might not have a fever or hearing loss. Sometimes ear pain is literally the only thing they complain about.
Interesting. Less systemic upset, perhaps.
Okay, diagnosis, you said it's mainly clinical, right? Based on history and the otoscopy.
Exactly. The notes are really clear. Investigations are not normally needed for straightforward, acute AOM. Diagnosis rests on the symptoms and those otoscopy findings.
Good to know. Saves unnecessary tests. But when might investigations be considered?
Only in specific situations. If you suspect a chronic perforation, you might culture any discharge. If you're worried about complications like mastoiditis or something intracranial, then CT or MRI might be used. But the notes say this is rare, especially in adults with just AOM.
Okay.
And tympanocentesis, putting a needle through the eardrum to get fluid, that's really reserved for complex cases like someone who's immunocompromised, or if treatment isn't working and you suspect complications. So for routine AOM, clinical diagnosis. Got it. Clinical diagnosis first. So once you've made the diagnosis, what's the management plan according to these notes?
Right, the what do we do part. Step 1 is symptomatic relief. Pain control is paramount. Paracetamol is recommended. Ibuprofen could also be considered.
Makes sense, it hurts.
Definitely. And give safety netting advice. Come back if things aren't better in about 3 days, or if they get worse. A warm compress against the ear might feel soothing too.
Okay. And the big question, antibiotics.
Yeah, always the question. The notes suggest a delayed or watch-and-wait approach is often appropriate because many cases resolve without them. You consider antibiotics if symptoms are dragging on for more than 4 days, or if the person is systemically unwell, immunocompromised, or has factors that put them at higher risk of complications.
So not automatic. If you do give them, what's first line?
First choice recommended here is amoxicillin, typically a 5 to 7 day course. If there's a penicillin allergy, then the notes suggest erythromycin or clarithromycin as alternatives.
Okay. Amoxicillin first line.
And the notes make a really key point. AOM usually only lasts about 3 days anyway and needs pain relief regardless. Antibiotics might shorten the pain duration slightly, maybe by a day, but, and this is crucial for counseling patients, they don't seem to reduce the risk of hearing loss later on.
That's a very important point about antibiotics and hearing loss.
It really is. Surgery, like making a small hole in the eardrum amelogotomy, is very rarely needed for simple AOM.
When might someone need admitting to hospital?
Admission is for the more severe end. If the infection seems really bad, if you suspect complications like mastoiditis, or if the patient is high risk. There are specific criteria for babies, too, based on age and temperature. Under 3 months with a temp of 38 degrees ECW or more, or 6 months with a temp of 39 degrees C or more, warrants serious consideration for admission.
Those are handy thresholds to remember. What about those persistent or recurrent cases? Is management different?
Yeah, slightly different pathways. For persistent AOM, where it's just not clearing up, you need to reassess. An ENT referral might be needed, especially if it's becoming chronic or you suspect complications. For adults with persistent AOM linked to allergies, the notes mention trying steroids.
Okay. And recurrent AOM?
That also usually means an ENT referral. The notes stress an urgent referral for adults with recurrent AOM if you have any suspicion of cancer, given those differentials we talked about.
Right, that red flag.
Yeah. For other recurrent cases causing distress or complications, a routine referral is fine. Each acute flare-up in someone with recurrent AOM is treated like a standard episode pain relief. Consider antibiotics based on severity, etc.
And if someone just isn't getting better on the initial treatment?
Reassess thoroughly. If they seem really unwell, consider admission. And definitely think again about other causes. Could it be otitis externa instead? Is there something else going on? Don't just assume it's AOM not responding.
Good point. Okay, that covers management pretty well. What about the overall outlook, the prognosis?
Generally pretty good. The notes state most cases get better within days to a week, often just with pain relief.
Yeah.
It usually resolves well.
That's reassuring.
But it does mention that if infections keep coming back or just won't go away, then further checks are needed, linking back to those ENT referrals.
Does this section mention any common after effects?
It does. It mentions eardrum perforation as a sequela, which can lead to discharge, otorrhea. And it notes that if that perforation and discharge hangs around for more than 6 weeks, that's when it might be classed as chronic suppurative otitis media, CSOM. Hearing loss and labyrinthitis, dizziness, are also mentioned here as potential outcomes.
Okay. And any prevention tips mentioned under prognosis?
Just briefly touching on recurrent AOM again, it mentions tackling risk factors, especially avoiding passive smoking, using antibiotics for each infection, and maybe antibiotic prophylaxis, but only under specialist guidance.
That passive smoking point really is consistent. So prognosis mostly good. But finally, let's talk complications properly. What are the serious things to be aware of?
Right, so while uncommon, especially in adults, complications can happen. They're divided into infratemporal, near the ear, and intracranial, inside the skull. The big worry infratemporally is mastoiditis infection spreading to that honeycomb bone behind the ear.
Okay.
Intracranially, the most severe are things like a brain abscess or meningitis, and any of these serious complications can, unfortunately, lead to permanent hearing loss.
That really highlights the stakes, even if rare. What's the full list of complications the notes give?
Okay, the specific list includes mastoiditis, facial nerve palsy causing facial droop, acute labyrinthitis, severe dizziness and vomiting. Intracranial ones named are meningitis, encephalitis, brain inflammation, and brain abscess.
Pretty serious list.
Yeah. And even rarer systemic things like bacteria getting into the blood, bacteremia, joint infections, septic arthritis, or heart valve infections, endocarditis.
And that slightly surprising potential long-term link.
Yes, that mention of a potential increased risk of nasopharyngeal cancer needing follow-up. Definitely a point that sticks in your mind from the notes.
It does. And OME glue ear is mentioned again here under complications.
Correct. It's listed as a very common consequence, especially in kids maybe up to half get some OME after an AOM episode. It's that persistent fluid without the acute infection. The main worry there is the impact of hearing loss on a child's development.
Right.
The notes also group them slightly differently. Intertemporal complications inside the temporal bone area include OME, hearing loss, dizziness, facial palsy, mastoiditis, petrositis, another bone infection nearby. Extratemporal ones are things like a neck abscess or those intracranial problems, abscess, meningitis.
Okay, so a whole spectrum from common and relatively mild like OME to rare but very serious like meningitis. That really covers the ground from these notes, a proper deep dive.
I think so. We've worked through the structure. Definition, causes, risks, the how, the who, the symptoms, diagnosis, management, outlook, and those crucial complications. Hopefully breaking it down like that and pulling out the high-yield bits makes it easier to digest for revision.
Definitely. Turning a list of facts into something more connected, we really hope walking through these notes helps solidify it for you and makes that revision a bit less daunting.
You know, this raises quite an important point for revision, doesn't it? Because AOM is so common, especially seeing kids, really nailing the diagnosis, knowing when antibiotics are truly needed versus when watchful waiting is best, and crucially, recognizing those red flags for complications or other diagnoses. That's the core knowledge you need from these notes. It's about being solid on the basics, but alert to the exceptions.
Absolutely spot on. Master the common, recognize the rare but important. Now, if you are revising and looking for more resources, don't forget to check out passthemsro.com.
And also freemsra.com for additional support.
Great resources. Well, thanks for joining us on this deep dive into acute otitis media.
Good luck with the revision.
Until next time.